Welcome. My name is DuPont. I'm a gastroenterologist at UT Houston and Memorial Hermann in the Texas Medical Center. I'm the director of the Inflammatory Bowel Disease Center here. So we're going to discuss inflammatory bowel disease today. I'm happy to answer any questions. We'll hopefully save those for the end, and then we'll be able to cover all those. Thanks. So what is inflammatory bowel disease? Well, these are two different entities, ulcerative colitis and Crohn's disease. Ulcerative colitis, as the name you can tell, involves the colon. This is associated with inflammation of the rectum and the colon, so the large intestine. The Crohn's disease can affect anywhere from the mouth to the anus, so anywhere in the GI tract can be affected. So what we see here are endoscopic pictures of the lining of the colon. You can see on the left, this is a normal colon. You can see the normal blood vessels. There's no inflammation there. And in the middle, we see ulcerative colitis, kind of the typical appearance with these small micro ulcerations. You don't see the blood vessels anymore because of the swelling that you see from the inflammation. On the right, you see fairly typical picture of Crohn's disease. Again, you don't see the blood vessels, so there's swelling, and then there's deeper ulcerations that we typically see in Crohn's disease compared to ulcerative colitis. So what causes the inflammation in inflammatory bowel disease? So the thought that what is going on is an inappropriate response of the immune system in the GI tract to the normal intestinal bacteria that lives in everybody's body. And these are people who are also genetically susceptible. So several things are going on. Here is a diagram that was in the New England Journal of Medicine about 10 years ago. And this is showing basically what we think is going on, and this is specifically Crohn's disease. So basically you have many, many bacteria in your intestine that your body is supposed to live with and not attack as far as the immune system. What we see in inflammatory bowel disease is the immune system is basically revved up and starts fighting these bacteria, thinking it's an infection that has to get cured, basically. And this inflammation leads to further damage in the lining of the intestine, which increases what's called the intestinal permeability, or gives you kind of leaky membranes of the GI tract. And so this allows more bacteria to enter and be exposed to the immune system, which further perpetuates the inflammation that we see, sort of this vicious cycle that we see in inflammatory bowel disease. So as I mentioned, normally people have a tolerance to the bacteria in their GI tract. So your immune system is basically toned down. There are anti-inflammatory enzymes basically that are released to decrease the inflammation or prevent the inflammation that we see in the GI tract. Normally, everybody has some mild inflammation, and it's important to have these inflammatory cells in the intestine because it destroys any bacteria that you're ingesting, basically, to prevent infections. In inflammatory bowel disease, this tolerance where the immune system is decreased is actually lost, and so the immune system is basically turned on, which leads to increased inflammation. So again, the two different entities we see in inflammatory bowel disease include ulcerative colitis and Crohn's disease, and there are definitely some differences. Ulcerative colitis, again, involves the colon, or the large intestine, and it's basically the first layer of the colon that is involved, what's called the mucosa. In Crohn's disease, this can lead to much more deep inflammation, and that's why we can see fistulas. These are abnormal communications from the intestine to other areas of the body. You can also see abscesses in the abdomen, as well as perforation or rupture of the intestine because the inflammation is so deep. In ulcerative colitis, basically about 100% of people have the rectum involved, and then it can extend further up to involve the entire colon, but basically you have to have the rectum involved. In Crohn's disease, again, it can involve anywhere from the mouth to the anus. They generally have less rectum involvement, so people with Crohn's colitis, about 50% of them will have the rectum spared. So this is rectal sparing that we see in Crohn's disease. The most prominent symptom we see in ulcerative colitis is diarrhea. Frequently this is bloody. There is often pain, but the diarrhea is the main presenting symptom typically. This is different than Crohn's disease, which the most predominant symptom usually, or most common symptom, is abdominal pain. You can't have diarrhea in these other symptoms, but abdominal pain is typically the most significant in Crohn's disease. Anal disease, this is different in ulcerative colitis compared to Crohn's disease. Anal disease is less common in ulcerative colitis and more common in Crohn's disease, with about 30% of people with Crohn's having anal involvement. Interestingly, what we've seen in the area of inflammatory bowel disease is how smoking affects inflammatory bowel disease. So smoking actually makes ulcerative colitis better in some patients with ulcerative colitis. However, we obviously don't encourage this because it obviously leads to much more significant problems with heart disease and lung disease. In Crohn's disease, we've definitely seen that smoking worsens basically everything. So you're less likely to respond to treatment, more likely to have surgeries and complications. So we definitely encourage people to stop smoking if they have Crohn's disease, and ulcerative colitis as well. So extra-intestinal manifestations in inflammatory bowel disease. So it doesn't necessarily just involve the intestine. So about 25% of people with inflammatory bowel disease will have one or more of these extra-intestinal manifestations. It usually correlates with colon involvement. So patients with Crohn's, colitis, as well as ulcerative colitis are more likely to have these extra-intestinal manifestations. And it can involve many different areas. The eye, this picture on the right, that is episcleritis, or inflammation of the lining of the eye. It can involve the skin. This is a picture of erythema nodosum, typically raised, tender areas, frequently on the shins. You can also see arthritis, different joint involvement, but also liver and lung can be affected. It's important to keep in mind that not all of these extra-intestinal manifestations parallel the intestinal activity. So you can get the intestine inflammation under control, but some of these other things may continue. Another important area we've seen in inflammatory bowel disease is the commonality of vitamin mineral deficiencies that we see. So looking at calorie and protein loss in up to about 70% of people with Crohn's disease. It's not well documented in ulcerative colitis, but we're fairly sure this is happening as well. Vitamin B12 deficiency is seen in about 50% of people with Crohn's disease. And this is because this vitamin is absorbed in the ileum, which is this area of the small intestine that's more commonly affected in Crohn's disease. And up to about 80% of people with Crohn's have ileal involvement. We also see other vitamin and mineral deficiencies, folate, vitamin A, and vitamin D. Vitamin D is very important in the area of bone loss, that we'll talk about in a minute, and this is seen in up to 75% of people with Crohn's disease will have a low vitamin D. This is also absorbed in the same area, the ileum. Calcium deficiency also contributes to bone loss. Iron deficiency is also very common. It can be caused by decreased absorption as well as from bleeding. So you see in ulcerative colitis, about 80% of people will have at some point iron deficiency, which leads to anemia. Zinc is also common. This can be from decreased absorption as well as just from diarrhea can lead to zinc deficiency. So bone disease and inflammatory bowel disease. The loss of bone density is seen in up to 50% of people with inflammatory bowel disease. This is caused by many different factors due to underlying disease as well as to the treatment that we use frequently with steroids. Osteoporosis, which is thinning of the bones, carries an increased risk of fracture, is seen in up to about 35% of people with Crohn's disease and in about 20% of people with ulcerative colitis. What we've seen in studies that the fractures involving the hips, ribs, forearm, and spine are 40 times more common in inflammatory bowel disease. Fortunately, this occurs in only 1 out of 100. However, it's obviously significantly increased over people who don't have inflammatory bowel disease. And as we mentioned, the causes of bone loss are multiple. These include steroid use, malnutrition, resection of the ileum, the portion of the small intestine, vitamin D and calcium deficiency, as well as to immobilization, being bedbound when you have significant symptoms, as well as indirectly due to the inflammation that we see in IBD. So prevention is very important in bone disease. It's important to get adequate dietary intake, and your body really would rather have this in a form of diet rather than in pills or supplements, but frequently this is required. Other important factors that we see in the population in general that leads to bone loss are smoking and excessive alcohol use. Also important is regular physical activity with weight-bearing exercises, and obviously it's important to control the inflammatory bowel disease. People with inflammatory bowel disease, it's important to undergo periodic bone density measurement. This is a very easy test to do. It's a bone density scan. Typically we do this generally about every 2 years. Colon cancer, this is also another important area in inflammatory bowel disease. Basically, your risk is increased with inflammation from ulcerative colitis or Crohn's colitis that involves the colon. What we've seen traditionally in ulcerative colitis is this exponential increase in the risk of colon cancer over time. So that's one risk factor, is the duration that you've had symptoms. Also, more of the colon involved increases the risk. This is some data based on some older studies, and so we hopefully are doing a better job at preventing this nowadays. Crohn's colitis, initially when people looked at Crohn's disease in general and looking at the risk of colon cancer, there was not an increase in risk of colon cancer. However, this was incorporating people who just had small intestine inflammation, and so when you exclude the people who don't have their colon involved, the risk does increase to about the same levels as ulcerative colitis. So it's important for everybody who has colitis, whether it's ulcerative colitis or Crohn's colitis, to undergo surveillance colonoscopies with biopsies. So colonoscopy is important, although not entirely pleasurable, but it has been shown to decrease the risk of colon cancer as well as to catch colon cancer earlier on. So what we see in inflammatory bowel disease is a progression from inflammation to what's called dysplasia or pre-cancer, and then if there's more damage that's done, can turn into cancer, and it can look completely normal. It can be totally flat, and so we really have to just take biopsies throughout the colon somewhat randomly. We're getting some newer techniques, but it hasn't replaced taking the random biopsies throughout the colon. What we see without colonoscopy surveillance is in those people who develop colorectal cancer, 60% will have advanced colon cancer when they're diagnosed, which is when you can't treat it surgically. With colonoscopy in those who developed colorectal cancer, the risk of advanced cancer is reduced to about half of what we see when you're not undergoing surveillance colonoscopy. So it's not perfect, but it certainly decreases the risk of advanced cancer. So in general, we evaluate people with colonoscopy every 2 years after you've had symptoms for 8 to 10 years. If you've had the entire colon involved, then we start at 8 years. If it's less, then generally 10 years, if it's just left-sided colitis. After 20 years, because the risk is increased over time, then we start doing it every year. And hopefully in the future we'll have better tests, less invasive, and make it easier on people and don't have to drink all the prep. Another important area that is often overlooked in the area of inflammatory bowel disease is irritable bowel syndrome, which is seen in the general population about 15% and is significantly increased in people who have inflammatory bowel disease. And it it doesn't always mean that any kind of symptoms of abdominal pain or diarrhea are due to the inflammatory bowel disease, but may be due to irritable bowel syndrome. So what irritable bowel syndrome is basically recurrent abdominal pain or discomfort that is associated with improvement of pain with bowel movement and or pain or discomfort associated with change in frequency or form of stool. So as I mentioned, it's very common to have both irritable bowel syndrome as well as inflammatory bowel disease. We see IBS symptoms in about 60% of people with Crohn's disease who are in documented remission, so they don't have evidence of ongoing inflammation. This is also seen in 40% of people with ulcerative colitis in remission. It's very important to distinguish between the two, which can often be difficult, because you don't want to aggressively treat their inflammatory bowel disease if this is irritable bowel syndrome, which is treated differently. You don't want to treat with high doses of steroids and things for irritable bowel syndrome. Some of the things that help distinguish whether symptoms are due to IBS versus IBD are the variability from day to day. So IBS symptoms can change from one day to the next, which we don't typically see in inflammatory bowel disease. So one day you can do horrible, the next day totally asymptomatic without any problems, and that's more consistent with IBS symptoms. There's also an increase in IBS symptoms associated with stress. People frequently do much better when they're on vacation or away from work. There's other associated symptoms include anxiety as well as depression. It's also important to keep in mind that IBS symptoms are unlikely to cause problems at night. So people who have IBS don't typically wake up in the middle of the night due to the pain or diarrhea, which we do see in inflammatory bowel disease. The pain and diarrhea can wake people up at night. Another interesting area is small intestinal bacterial overgrowth. So just as some background, everybody's got tons of bacteria in their GI tract. There's actually 20 times more bacteria in your body than you have cells. About 100 trillion bacteria exist in the GI tract. The majority of this is in the large intestine, and it helps break down the food that we eat and creates gas, and that's one of the reasons people get gas other than swallowing air when you eat. There's very little bacteria in the upper small intestine because of the contractions in the small intestine sweep all the old food and bacteria into the large intestine, and there's a valve, the ileocecal valve, that separates the colon and the small intestine that prevents bacteria from basically going upstream into the small intestine. What we see in some people is this overgrowth of the normal bacteria in the colon growing in the upper part of the small intestine. So these people, when you eat, the bacteria is exposed to the food and ferments and digests the food and creates gas as a byproduct of this, and can lead to significant bloating and malabsorption as well as diarrhea and abdominal pain. How we usually figure out if you have this is with a breath test. Basically, you ingest a type of sugar that gets broken down by the bacteria in the GI tract, and then as the bacteria breaks down the food, it creates gas that is given off in the breath, and so we collect breath samples and measure the gas that's produced by the bacteria. So looking in inflammatory bowel disease, specifically Crohn's disease, has definitely been associated with an increased risk of small intestinal bacterial overgrowth. In this one study of 145 people with Crohn's disease, 20% had breath tests consistent with small intestinal bacterial overgrowth. And this is due to several factors. One is surgery, had their ileum removed, their ileocecal valve. Also with blind pouches after surgery, this can also lead to stasis of the bacteria in different limbs of the intestine that can lead to bacterial overgrowth. In this series of patients who had the positive breath test with Crohn's disease, they were treated with different antibiotics, and the vast majority significantly improved as far as their symptoms, including bloating, diarrhea, abdominal pain. So again, not every symptom in people with inflammatory bowel disease is due to the underlying inflammatory bowel disease. There are other things that should be evaluated as well. So treatment of inflammatory bowel disease. So the first with ulcerative colitis, so the goal of treatment of ulcerative colitis, these include induction and maintenance of remission, so get people back to normal and keep them normal without symptoms. You also want to get people off steroids. We know steroids lead to significant problems with bone loss, and I'll talk a little bit more about that in a minute. We also want to improve quality of life, as well as reduce risk of future surgery, as well as colon cancer. So the treatment of ulcerative colitis is based on several things. One is the severity of inflammation, and the other is location of the inflammation. We generally like to use a topical therapy if we can, if people will tolerate it. If you have just the rectum involved, which is in the first picture, this is the last 15 centimeters of the large intestine. This frequently responds well to suppositories, so you don't have to swallow the pills that goes all the way through your intestine to get to where the inflammation is. So if people tolerate it, this generally works better than oral medications. This is also similar with involvement of just the left side of the colon. So in picture 2 and 3, this is the rectum and the sigmoid in picture 2, and then in picture 3, this is what's called left-sided colitis. And frequently we use enemas for people who have inflammation in this region, and generally what we do is use these at night when you're laying in the left on the left side, and it basically coats the lining of the left colon. And people who have more involvement of their colon, these are people who will need oral therapy to get to the first parts of the colon. Frequently, the combination of topical as well as oral therapy is more effective than one alone. So there are multiple different medications that we use in ulcerative colitis. There are 5 ASA medications. There's several of them. That's definitely been shown to be effective in ulcerative colitis. It's important to really maximize the dose of these medications before giving up on them and escalating therapy to something else. So you really need to go up to about 4.8 grams a day of these medications before you give up on them. People frequently will respond to lower doses, but it's important to go up, maximize the dose before you move on to other treatment. Steroid foams, these are also topical therapy that we frequently use for left-sided disease. The combination of the steroid foam with topical 5-ASA medications are also more effective than just one alone. Oral steroids such as prednisone or budesonide, these are generally reserved for people who don't respond or who have more severe symptoms, more debilitating symptoms with significant effects on quality of life. An important aspect of steroids is it's not a good long-term treatment. This has been shown to not be effective in the long term. It also leads to multiple different side effects and complications that we see. Another important aspect, if you're going to use steroids, is you really have to be asymptomatic for 2 weeks is generally what I do before you start tapering off this medication. This is different than what we see in some other things like asthma or COPD, where people generally put on a tapering dose. But what we've seen in inflammatory bowel disease is if you just start automatically tapering down, the inflammation is not under control, and so the inflammation comes back. You have to go back up on the dose of the steroid, and it's this vicious cycle where you can never actually get off the steroid. So it's important, I think, to be asymptomatic or back to baseline for 2 weeks before tapering off. So for people who are steroid refractory, who do not respond to steroids, or who are steroid dependent, then we need to escalate to other therapy. These include azathioprine or Imuran, 6-mercaptopurine or 6-MP. These are related compounds that are given orally in pills. It's important to monitor different blood tests when you're on these because of potential side effects of liver complications, as well as it can make your white blood cell count decrease to where you're more susceptible to infections. We could also see pancreatitis or inflammation of the pancreas on these medications in up to about 3% of people, 1 to 3%. The other therapy we use for these people with ulcerative colitis includes infliximab or Remicade. This is an IV infusion that's given periodically in an infusion center, which has also been shown to be effective for ulcerative colitis. For these medications, it's important to keep in mind that these suppress the immune system, and so you want to have a balance, whether you decrease their immune system too much and increase your risk of infections. So this is important to be evaluated for tuberculosis. There were several deaths associated with infliximab in people who had asymptomatic tuberculosis. So there's blood tests for this. Also, vaccinations are important before you start these, and these include hepatitis B, hepatitis A, and you don't want to give live vaccinations to people who are taking these medications. So for severe or fulminant ulcerative colitis, these people are generally admitted to the hospital, treated with IV steroids. It usually gets things under control. However, if people don't respond to roughly about 7 days of IV steroids, then it's important to evaluate endoscopically to basically to rule out this infection, cytomegalovirus or CMV, which we see in people who don't respond to steroids. And once you rule this out, generally what we go to is infliximab or Remicade. In the past it was cyclosporin, but we generally try to avoid this due to side effects. However, it's still used. Then also the other option is surgery, depending on whether there's a response or if a person just doesn't want to do the medication anymore. This is also obviously an option. So treatment of Crohn's disease. What we've seen in contrast to ulcerative colitis is that mesalamine, sulfasalazine, these 5-SA medications are less effective in Crohn's disease, unfortunately. Another difference is the role of antibiotics. What we've seen in people who have Crohn's disease, specifically with the colon involved, they can respond to antibiotics. Two we most commonly use are ciprofloxacin and metronidazole or Flagyl. It's important to keep in mind that the symptoms typically return when these are stopped. The rationale behind the use of antibiotics makes sense when we look at what we think is going on with the underlying bacteria in the intestine. We also use budesonide or Entocort. This has been recommended for mild to moderate ileocecal Crohn's disease. And basically this is a steroid that's released based on the acid level or pH in the intestine, and it's released in the last part of the small intestine, so it's in the ileum where it is effective, as well as in the colon as well. This medication is associated with less side effects compared to other steroids like prednisone. So for people who have refractory Crohn's disease or who are steroid dependent, we again, like ulcerative colitis, use azathioprine and 6-MP. It's important to keep in mind that these medications can take quite a while really to become effective. It can take up to 6 months to see a response to these medications. So we usually need other therapy if these are going to be started to get symptoms under control faster. Again, it's important to monitor blood tests, as I mentioned previously. Methotrexate, this is an injection medication that is also used for Crohn's disease and is not effective for ulcerative colitis. This is more commonly used in Europe, whereas in the U.S. we generally use more azathioprine or 6-MP. But methotrexate does definitely work in some people with Crohn's disease. It's important to be on folic acid supplementation because it can be affected and you can get folate deficiency. Again, like the other medications, you really need to monitor blood tests, liver tests periodically if you're on methotrexate. So the biological therapies for Crohn's disease, like ulcerative colitis, infliximab or Remicade has been approved for Crohn's disease. Also, we have adalimumab or Humira or certolizumab, which is Cimzia, and these are all injections. The infliximab is a continuous infusion that's given over a couple hours, and then the other ones are injections that you do yourself at home after getting some instructions from a nurse or home health. So what we've seen in Crohn's disease, looking at the optimum therapy, the people who are most likely to respond to medical treatment is with basically a biologic, which is anti-TNF, such as Remicade, combined with azathioprine. And this is a study looking at people as far as the steroid-free remission at 26 weeks. And what we see on the left is azathioprine, about 30% who were treated with azathioprine alone were in steroid-free remission, whereas with infliximab by itself, 44% were in remission, and the combination of both was statistically more significant. Close to 60% were in steroid-free remission. So this is generally what we're typically doing now is doing the combination, or at least explaining the probability of success is higher with the combination of these. So who should be considered for early biologic therapy with those medications like infliximab, Humira, those? Well, these are people who have at least 2 or more of these clinical variables that suggest a poor prognosis. These include young people, less than 40 years of age, whether steroids were required for the initial flare of symptoms, and people who have deep ulcerations or fistulizing disease, also multiple antibodies to the intestinal bacteria. And I hadn't mentioned this, but there are several antibodies that are associated with Crohn's disease, and these are basically abnormal antibodies that are formed to the intestinal bacteria. Also, people with perianal disease are more likely to have more complications down the road. Also, people with more extensive disease, such as in the upper part of the small intestine and the duodenum. Also, people who don't respond to steroids after 2 to 4 weeks are more likely to have a poor prognosis and require biologic therapy, which should be considered earlier in these people. Another important area that gets a lot of press lately is the risk of lymphoma, both with Crohn's disease as well as by itself, as well as on the various treatments that we use. This is a diagram looking at of 10,000 people, and the risk, although significant with immune suppression, the risk is increased. The risk is very small, so about 6 to 8 people out of 10,000 will have this complication of lymphoma or cancer of a certain type of cancer. So it is an important thing to keep in mind, though, when using these medications. Also, the risk of serious infection. This is also increased in the therapy that we use, but also in Crohn's disease by itself. And the risk of serious infection includes risk of developing abscesses in the abdomen, which people with Crohn's disease are more predisposed to as without these therapies. This was one study looking at over 6,000 people with Crohn's disease and looking at the risks associated with serious infections as well as a risk of mortality or death. And what they found in this study was that only prednisone and narcotics or pain medications were associated with increased risk of serious infections and death. So these are very commonly used, and people don't think twice about it, but are more concerned with the other medications. But we really need to keep in mind that prednisone and narcotics can lead to significant problems, and these are reasons that we try to avoid these. So looking at the risk of complications when looking at therapy as well as odds of developing complications, this is a model of a person who is at increased risk of developing complications. This is an 18-year-old female with Crohn's disease. has small bowel and perianal disease, as well as elevated antibodies to the intestinal bacteria. So the risk of developing complications, which include stricture or fistula, is significantly increased without treatment. So the top line in blue is with no treatment versus the red line below is with treatment. So this person's risk almost goes up to 100% if there's no treatment. And so obviously the risk is much greater if no treatment is initiated compared to initiating treatment. And that is it. And with that, we can take some questions. So the question of their specific brand of vitamin D they recommend over others, generally nothing specific. They haven't been really compared, so it's hard to know, which exactly, if there's one that's more superior than others, but I think generally they're pretty interchangeable. So the next question, are there any current clinical trials for Crohn's disease? And there definitely are. There's a lot of studies going on now. In fact, there's a lot of people say there's more studies than people to enroll in them. So there's definitely options for different studies in both Crohn's disease as well as ulcerative colitis that are available. So here's another important thing to look at are probiotics, good to take if you have Crohn's disease. And so basically this is taking good bacteria, or what's thought to be anti-inflammatory bacteria. There's been several studies in Crohn's disease as well as ulcerative colitis, and the jury is really still out. Some have showed an improvement over placebo, and others have not. Although they're safe, and so I definitely advocate the use of probiotics, and we just don't have a lot of data right now to say that definitively this significantly affects Crohn's disease, but it's well tolerated, and so I have many people who take these. Okay, here's another question. Please discuss your experience with patients altering their diet as part of their treatment. Have any of your patients found any benefit to a gluten-free, dairy-free, sugar-free diet, grain-free? Yes, definitely. Some people definitely respond to this. The whole issue of gluten is interesting. There are different varying degrees of gluten issues. There's celiac disease where you basically have an antibody to to gluten. There's also gluten sensitivity with you don't actually have celiac disease, but you're sensitive to the gluten, and people definitely respond to a gluten-free diet in these cases frequently. There's many other different potentially exacerbating foods that people can eat. There's several that are more likely to produce gas and cause symptoms. Dairy-free is also important. There's significant increase in lactose intolerance in specifically Crohn's disease involving the small intestine. So that's definitely important in some people. In general, I don't say people should avoid all dairy products. Certainly, if you don't have symptoms, you shouldn't avoid it. Just because this can predispose people to bone loss and other issues that you're not getting in the diet if you're not getting enough calcium and vitamin D. And the overall other issues of what's the good diet and that kind of thing, there's really no great data right now, and generally we say if there's something that definitely bothers people, then maybe you should avoid it, at least until your symptoms get under control. However, overall, elimination diets for everybody I don't think should be advocated, certainly if you don't have symptoms. And here's another question. I've heard eating a lot of sugar is not good for someone who has Crohn's, and there definitely is an association with increased carbohydrates, simple sugar in the diet that increases the risk of developing Crohn's disease. It's not entirely clear if that's a compensatory or you're compensating for loss of calories and things due to the underlying issue of Crohn's disease, but there is definitely an association that's been seen in studies. So here's another question. If you have been diagnosed with IBS, can this be a pre-existing factor leading up to Crohn's or ulcerative colitis? IBS doesn't cause inflammatory bowel disease. It could be several things. One, somebody has IBS and then develops inflammatory bowel disease. It could be that the symptoms of IBS, abdominal discomfort, diarrhea, that kind of thing, can be due to undiagnosed inflammatory bowel disease. But like I said in our discussion, there's definitely an increased risk of having at least the symptoms or the diagnostic criteria for irritable bowel syndrome in people who have inflammatory bowel disease. So here's another question about the J pouch, and this is a surgery that's done for ulcerative colitis as well as other indications, but basically it's creating a pouch. You remove the large intestine and create a pouch of the small intestine, the ileum, so you're basically connected back to where you don't have an ostomy and you're able to use the toilet. Generally what happens is once you have your colon removed, you don't absorb as much fluid, and so people typically have to go to the bathroom roughly 4 to 6 times a day, but it's more controlled, so you're not bleeding and that kind of thing. So it's not uncommon that we see this, and it can lead to long-term problems in certain people, such as pouchitis or inflammation of the pouch. Generally, surgery is tried to be avoided in favor of medical therapy, but some people either don't respond or they're just tired of dealing with medication and that kind of thing. And so we definitely see people with the J pouch, and it's kind of like I mentioned, you're getting rid of the colitis, but you still have to go to the bathroom frequently. So it's not a perfect cure for everybody. And a follow-up question, can a J pouch last for as long as you live? And the current thought is yes, definitely. And obviously, if you've had it for a long time, that's a very encouraging sign. So I think the odds are good. here's another question: Is excessive burping an issue with someone that has Crohn's disease? It can be, especially if you have involvement in the upper GI tract and the top part of the small intestine as well as the stomach. It could also be totally unrelated, that it's due to reflux, those kind of issues. It's also possible that it could be due to the bacterial overgrowth that we mentioned. That usually causes more bloating and less belching, but it can be associated with that. All right, and here's one last question. Any new studies going on with medicine for Crohn's disease? And we kind of mentioned this before, but yeah, there are definitely new trials going on, new different mechanisms for specific treatments. This is also evolving, so there's always options as far as new studies. And with that, I think we will wrap it up, and this will be available online after. I really appreciate everybody joining in, and there were some great questions. Thank you very much.